Hello and welcome to EuroPCR 2024. My name is Felix Mahfoud from University Hamburg, and I'm here together with Professor Giuseppe Rosano from London, a heart failure expert. I'm very happy to discuss with you interventions in chronic heart failure. So Giuseppe, tell us a little about the unmet need. What's the problem with chronic heart failure? There are many drugs available that work well, but is there an unmet need for interventions in chronic heart failure?
Felix, first of all, it's a great pleasure to be here at EuroPCR 2024. Absolutely, there is an ample need for interventions in heart failure because we always focus, whenever we talk about drugs, at the main difference between treatment and placebo. We don't look at the unmet need, and even the most recent trials, when you look at the area under the curve, so what is the residual risk? The residual risk is very big.
Remains high.
I mean, we talk about high risk in patients after an acute myocardial infarction. That is 8%. But in heart failure, it's 15%. So how do you call it? High, very high. Mm-hmm. So there is a place for interventions, for different type of interventions at the right time once the therapies have been optimized. But there is also space for monitoring. So on one side, interventions and like interatrial shunts and neuromodulation, that is very important, possibly in the future even ablation and renal ablation, because that has an important effect on the sympathetic and renin-angiotensin system.
Let us discuss a little more, a couple of minutes, spend some time on the devices that are available and are under investigation. At ACC, an important trial in intraatrial shunting has been presented. Tell us what that is, and what on a global, on a broader perspective, what does that mean to patients? Is that clinical relevant?
It is very clinical relevant. First of all, what is important is to select appropriately patients. Then, if you select appropriately patients who may benefit, and these are especially those with a preserved ejection fraction or those with mid-range ejection fraction, then unloading the left atrium and with a shunt improves the exercise capacity, improves quality of life, which is what then leads to the high hospitalization rates in patients with heart failure. But also, the pulmonary congestion is also associated with some non-cardiovascular comorbidities like COPD, and that may worsen in patients with preserved. So there is a big space for the interatrial shunt. What is important is to select patients, and what we need to do now is to identify the right time in the right patient for the intervention.
You mentioned neuromodulation as being another target for devices. Which devices are in the play, and what should an interventionalist be aware of when talking and discussing with patients about neuromodulation in heart failure?
Yeah, first of all, I have to say the neuromodulation is very important because no matter what we do, we treat patients with anti-neurohormonal drugs. I mean, we never get to the maximum dose of the ACE inhibitors, ARNI, or beta blockers, and therefore there is some space left for the neuromodulation to start. I mean, there are devices that are already been approved, and they stimulate the vagus, and other devices that are currently being tested. There's not an edge of one to the other. That we don't have comparative data. But of course they work, and the effect, of course, has not been tested in mortality, morbidity. So we have data. More data have to come. And what is important is that they've shown to improve the quality of life and the exercise capacity, which is important.
Which is an important endpoint in clinical practice as
Absolutely.
Well, right?
Yeah.
You also briefly mentioned monitoring, which is an interesting topic as well, and you need interventionists to place the monitors, right?
Yes.
So tell us a bit about where you see this heading, and what are potential patients that benefit from intravascular monitoring?
I believe that each patient that has more than one hospitalization for heart failure should be monitored. And of course, the monitors, the invasive monitors, are those that give us the best and more accurate readings. And they've been shown to reduce mortality and morbidity. I mean, they don't do that directly, but just because they increase the care of patients, and therefore they tell you exactly when to up-titrate your diuretics, when to up-titrate your drugs, or when patients are starting to become unstable. So it is very important. We often see these frequent flyers. Patients come in and out, in and out. And also, if you talk about costs, at the end, just by reducing one hospitalization per year, it pays more than what the device costs. So I think we should be promoting more and more the use of monitoring, and because the pulmonary monitoring is not just effective for the life of patients, but it's also cost-effective for our society.
Giuseppe, thank you very much. I really enjoyed the discussion with you. I learned that there's a lot of synergy between drugs in heart failure, but also the potential to even further improve outcomes in patients with heart failure. More to come. Stay tuned. Thank you very much for joining us.
Thank you.